Hi, welcome to the latest ECIST podcast. My name's Nick Holding. I'm an improvement manager with the Emergency Care Improvement Support Team. And I'm delighted today to be joined by the team from Nova Scotia Health in Canada, who have recently adopted the Safer Patient Flow Bundle after discovering this online last year and then engaging in a few conversations. And what we're going to hear about today is how they've taken the learning from the Safer and applied it and made it their own, very much their own in their own organisation. Guys, just want to introduce yourself. Melissa, do you want to go first?
Hi, my name is Melissa Buckler, and I am a manager for planning, development, and system performance with the Integrated Acute and Episodic Care Network within Nova Scotia Health. And I'm also one of the co-leads for the Safer F implementation within our hospital sites across the province.
Thanks, Melissa. And Greg?
Greg Arsenault, Quality Improvement Safety Leader with Nova Scotia Health, the Eastern Zone, and with the Safer F project, I am a quality coach for the Eastern Zone two initial teams.
Brilliant, thanks very much. So just a bit of background for our viewers, Melissa. Can you just tell us a bit more about Nova Scotia Health and then how you came to develop the Safer F model?
Sure thing. So Nova Scotia Health provides health services to Nova Scotians and to also other Maritimers in the Atlantic provinces in specialized cases. We operate hospitals and health centers and community-based programs across our province. We have several employees, doctors, researchers, and learners, as well as our volunteers that provide healthcare that is needed. And we work with many community groups, schools, governments, and foundations, and auxiliaries, and community health boards. And we are across, there's 4 geographical zones that are made up Nova Scotia Health. We have Western Zone, Northern Zone, Eastern Zone, and our Central Zone. And we work to strive every day to improve the quality of care for patients and Nova Scotians who need our services. You also asked me about how we came to implement Safer within our province. We started back in 2018, actually, looking at how we can implement the Safer bundle, and this was with a different group of leadership at the time. And it was adopted within some units, but not all units. And those units that did adopt the Safer bundle were quite effective in making some nice changes to be able to improve patient flow. But as we all know, COVID-19 came along and definitely turned us upside down. So back in May of last year, we had an opportunity to relaunch Safer within our Nova Scotia Health in our province, and we looked at adding the F to Safer, calling it the Safer F Patient Flow Medicine Bundle, and the small f stands for frailty, which I can explain a bit further. The other thing is that we had decided to implement this time with a quality improvement approach. So we introduced 8 teams across the province, so 2 per zone, to work with our provincial team and our quality improvement director in the Central Zone. And we established a quality improvement collaborative that would help the teams move forward in implementing each component of the Safer F bundle.
That's brilliant. So you touched on the F there about what you've added the F to the Safer, which I think is brilliant. And that's for frailty. Why did you think that? Why did you find that was important? I think it's really interesting for us to learn from that, actually, because and how we may bring that back from Canada and see how it may be useful in the UK. So why was that important for you to introduce the F?
Well, frailty is something that is the baseline characteristic that folks bring when they arrive into our hospitals. And it also identifies kind of areas of vulnerability for folks that are living with frailty. Our organization has put a great emphasis on frailty and the importance of understanding and knowing how that can impact length of stay, barriers to discharge, being able to have the person move back to their home. So we actually have established a frailty and elder care network as one of our clinical service networks for the province, and it's a mandate that we look at frailty more broadly. And so we decided to add this on to SAFER, simply because we felt that, you know, we should understand frailty at the very beginning of admission, and that should be considered by the multidisciplinary team. It should be considered when coming up with care plans and what's going to happen. And for discharge, it can also help the patient and family understand more about their health and what is happening for them. And it also really identifies the vulnerabilities that people have challenges with. And so when that comes to light, we can do a better job of addressing that and tackling those barriers so that people can hopefully return back to where they were living and live safely in their homes.
Yes, that's fascinating. Really interesting about that, particularly early identification for patients. I think that's really, really critical. So, Greg, just turning to you for a moment, as a coach in the organisation, how have you? I guess you've been there at the forefront in terms of connecting with the teams who are delivering care at the front line. From your perspective, how have you found the introduction of SAFER F on the units, and what's been your approach?
Well, we go back to
the
beginning.
beginning. I guess we identified a couple of teams within the Eastern Zone that were ready for the implementation of SAFER, created a teams, and decided early on that we were going to work together with both teams so that they could learn from each other as they were discussing any changes that were happening, and had some pretty significant success with that. So those teams would meet on a weekly basis, developed a quality improvement charter to start, identified what PDSA cycles we were going to pull from a guidebook that was created to help us get started, as well as initiate some that the leaders thought were important that weren't part of the guidebook. So each week on Thursdays, we would meet as a team. So the two directors, the two managers, myself, project manager, and interprofessional practice and learning, to go over those PDSAs, to review any data that we had from the week before and make changes, as well as talk about any challenges that were happening and successes that were occurring as well. And so, some of those early PDSAs that we had identified were bullet rounds, initiating bullet rounds on both teams, and with some initial challenges that started out, they were, overcome, and both are succeeding with those with implementation of the bullet rounds now. 4 questions were another one that were asked early on. Both of those were part of that initial guidebook. The teams had decided as well to be a little creative and started tracking the frequency of a physician review prior to or 24 hours prior to a patient's expected discharge date. And we moved on from there to looking at EDDs, as well as the visualization board, which started off for us as a whiteboard, and moved to a digital board that is now used on both units for real-time tracking, and also allowed us to scroll through with a PowerPoint presentation. The data that we were reviewing as a team weekly could then be seen by the frontline staff at both units.
What I find really interesting, what you just described there, and I don't want to put words in your mouth, but I got a sense that there was a iterative approach where you've got a kind of learning mindset where you admit there was challenges to start off with and ongoing challenges, but it's how you overcome those challenges. So again, without wanting to put words in your mouth, is that what you found?
Absolutely, and we were really clear at the outset that it was okay to not have success on anything that we tested. So take away the fear of failure and try something. see if it works, and if it does, we'd have the data to support it, and if it didn't, we'd also have the data to support that, and stop doing it.
Yeah, and that's such great learning to be able to take that approach and set those kind of foundations from the outset. Using that, I love your line there. You take fear out. Just give people permission to try something and see where it goes. And sometimes it may fail, but it's learning from what happened as a result of that. From your perspective, Melissa, anything, from your perspective of looking across all the province, have you got any other observations that build on what Greg said?
Definitely. Not only was Safer F new to some, but also the quality improvement approach was also new to some. And one of the things we were trying to build at the same time of rolling out Safer F is our organization is really trying to build QI capacity. And hearing those words of, small tests of change, it's okay if you fail, you tried it, and then you just move on to improve it. So these are some things that our teams probably aren't used to hearing, especially going through COVID, where it was just, it's go time and there's no time to slow down. But the fact that we're giving and allowing folks to come to these sessions and learn that quality improvement approach has really we've really seen huge benefits. And I will say today that it's not about necessarily always the numbers on a PDSA cycle run chart. We are hearing about inherent changes in the culture of the units and how the teams are now working together, and in some ways maybe better than they have in quite a long time. So there's some really nice outcomes that way as well that we're not necessarily capturing from a data standpoint, but we are hearing the excitement, and it's actually giving me chills, to be honest, about how this is moving things along for our teams, and that they're seeing this themselves, and there's a feeling on their unit that things have changed for the better. In addition to that, what I'm also finding as a kind of maybe a balancing measure or an unintended outcome is that, patients, and this is what we've been aiming for, is patients are really now becoming more informed through this Safer F work about, where they're at today, where they're going to be going today, who they're going to see today, those kind of 4 Qs, 4 questions of the Safer F bundle. And I'll quote one of the RNs on one of the units in Glace Bay. I just saw this quote: "The more the patient knows, the smoother the discharge goes." And I'm like, that is, to me, the essence of what we're trying to accomplish here. We're really starting to see it, and we're so excited to see the teams and super proud of them, because they really have put in a lot of hard work on this, and the rewards are being seen.
Yeah, I mean that quote's great, isn't it? And I think we can't communicate enough with our patients. Give them the power to know their own story. So it's
Yes.
I mean, just touching on, I'm going to come back to you now, Greg, if that's okay. I think you touched on some of the benefits that you saw before, and we just talked about that. And so I think you described something that was one of the units had just got on and done something on their own, and figured something out and tried something out without following the rules almost. And I think that's indicative of to a certain degree the climate that you've created. Are there any other? I mean, Melissa was touching now on some of those unintended outcomes that you've seen. Have you seen any or heard anything from some of the weekly conversations? Any other distinct benefits that you've found?
I think one of the key benefits would be the improved communication within the team, and I think Melissa's touched on that as well. But previously, there would have been multidisciplinary work happening, but in silos, individually going to the clinical nurse lead to have those conversations, and now those conversations are happening, 1 to 2 minutes per patient, where everybody's hearing the progress. They can care plan in real time. And everyone sort of knows what the obligations are to move towards quicker discharge for that patient. In addition to that, we've seen where, a particular PDSA was around identifying a red days for rehab, OT, PT. And so on one of the units, they were able to hire a full-time physio assistant, and we've seen significant benefits there where they're actually down to 0 red days for the past 8 or 9 weeks, where previously we were looking at some weeks with 20 red days for that internal barrier. So communication is definitely the key component, both within the team and with the patient, but we're also seeing some of those other benefits with concrete data to support the change.
Yeah.
Yeah.
Melissa, go on, Melissa.
I just want to also add that, with this work in particular, we did look at, the variation that is occurring amongst the units across the province with regards to their team complement. And so we were able to wrap some funding around this for these 8 teams to go through and to get their teams up to complement. And we just heard a story this morning about the impact that, hiring a social worker has made for their unit, that has made huge progress in actually admission avoidance, not even having the person end up on a unit because they were able to deal with that, that social determinant of health that the person was struggling with, and they didn't even have to land on the floor. So that's another enabler. But what it allowed is just that, you could have every person that you need on a team to wrap around a patient to get them home. So that's been another a big win, and it's starting to show the impact of how these new FTEs are really helping to make that team a whole.
For me, what you're just describing there is really the essence of the safe patient flow bundle, and how it was established in the first place was around purely about identification of delays and waits for patient. It's a flow bundle. It's identify those waits and delays, and the Greg talking about those red days. I mean, they're all just waits for patient, aren't they? And how you identify them, and using red and green days, using principles of the theory of constraints, identify what are the barriers. And then sometimes you may need to put in an intervention, sometimes not. But you've described it in a way which is looking for the reasons, looking for the constraints, and then finding solutions for those constraints. And that's very much the essence of what the bundle is all about, is it helping to dig out where those constraints would have existed for years.
Definitely.
And now it's bringing that to the surface. So just as we sort of wrap up, Melissa, I'm just going to wrap up with you in terms of brief reflections on where you've come from over the last 12 months or so, and then what's next for the Safer F bundle with you.
Well, I'll have to say, it's to the credit of the teams that are moving this along. We're providing some structure and some tools, but it's really them that have made these changes, and it's local changes. And that's the thing, the local changes that people can actually see happening right on their unit, that benefits their patients and improves the staff morale as well, because they feel that they can make a difference. So with all these wonderful learnings that we've had, we are going to be running another quality improvement collaborative with probably a larger group of teams, because this first group, we have learned so much, and we can, they've hung in with us along the way, because there has been bumps in the road at our end too. But we're looking forward to that next cohort coming through, and we are going to leverage the teams that have been involved previously. Like, they are the superstars, and we need to showcase this, and that helps to build that buy-in too, when you have units talking to units and not leadership talking to units. So I think that's really makes the difference, and everyone's in this together. And I think if these 8 units did what they did, it's going to be fascinating to watch as this spreads across Nova Scotia Health.
Yeah, it's brilliant to hear, and great to hear about that sharing between teams as well, and using your previous cohorts to help support future cohorts, and almost supporting people like Greg who are coaches out there, but building a network of coaches as well. It's great to hear, and it's been lovely to hear your story, particularly over the last 12 months. So and just to capture it in this podcast has been really interesting for me to be able to help describe that story. So wish you all the best of luck with the next phase of your journey. Well done. It sounds like you, as I said before, you really have grasped the essence of the Safer Bundle. But for today, Melissa, Greg, thank you so much for taking the time out to chat to me, and maybe we'll catch up again in a few months' time. We'll do another podcast on your progress.
Yes, that'd be lovely. Thank you, Nick. And we do want to put kudos out to you and to Pete, who have guided us along the way here. So thank you to you.
Thank you very much. See you soon.
Thanks, Nick. Bye.